Salsa y soul.
Soul and salsa.
Salsa y soul. We have so much in store for you all. Hello and welcome to Soul and Salsa.
And yes, bienvenidos a Salsa y Sol, aquí otra vez.
Yes, we're two sisters, Latina and African-American, Latino and Negra come together and we share and we talk about life. So today is Casual Friday, and we have two special guests. We are so excited. And remember last week, right, sis, Rev, we talked about the vaccine to take or not to take. And what did you say, Rev? You said, listen, this is what? Your choice.
Absolutely. And the most important thing is be informed, right? We stress that. You got to inform yourself. You have to educate yourself.
That's right. And so we have a special guest. Her name is, drum roll, please, Dr. Marlene Taylor. Hey, Dr.
Welcome, Dr. Marlene. Wait. Dr. Marlene, you have to say it. You have to say Soul and Salsa.
Soul y salsa.
Yes.
I'm working on my voice. I need some voice lessons from Michelle, but
you're good. You're good. I just want to make sure, Nilsa, Rev, can you hear Dr. clearly? Can you hear her?
Maybe, yeah, a little bit. If you can speak a little bit louder, Doctor.
Okay.
Okay. Perfect.
Soul y salsa.
Perfect. Well, we're going to get right into it. I want to introduce you all to, she is our family, doctor, friend, sister. She started out as my mom's doctor, and then, yes, full transparency, then my uncle came and he took her, but then I took her as my friend after. And we have so much in common, from interracial marriages to sons and spectrum life. She is amazing. Her oldest is overseas, and she just has an amazing life. And we wanted to bring her on, and Nilsa will tell you the formality about Dr. Taylor.
Yes, gracias otra vez, Dr. Marlene, de estar con nosotros. And Dr. Marlene is the assistant director at Ryan Center. She practices family medicine. She's also at the Ryan Center, the HIV and addiction medicine director. So thank you.
Thank you for having me.
Thank you. Well, you know what? We're going to get right into it. Doctor, the question that Nilsa and I talked about was vaccine, right? To take or not to take. I know many people have taken it, full transparency, my mother and my husband, and I'm going to be next. But there's so much controversy over this. And the Rev and I talked about the historical aspect, from the Latino history to the Black history, but we are not the physicians. We are not the experts, right, Rev?
Absolutely, we're not, and we want our people in our communities, brown and Black communities alike, to be informed. So we are so grateful that you're here as an expert.
By the way, Dr. and Rev, Michelle, are in New York. Reverend Nilsa is in Miami.
Okay? You see the palms.
You see that she's wearing a no sleeve blouse. Okay.
Yes, thank you. It's such an honor to be your guest this evening, and I applaud you for such an amazing platform to be able to educate and inspire and just talk about topics which impact not only our communities, Latino and African Americans, but the world, right, at large. And so with that being said, I want to start with just some foundation and basic principles around where we are with COVID and the vaccine. As I, spoke with you earlier about, things are changing literally every minute, from the guidelines to the recommendations. And so what I hope to be able to give you this evening is just a better idea around the facts as we know them, and then hopefully people can make informed decisions. You know, as you mentioned, Ilsa, being educated and just being aware of the facts so that you can make an individual decision around the vaccine. I have a slideshow, which is just a few slides, but it's just going to give us some basic facts around, we had a town hall meeting with the staff at Ryan. Being on the front lines, of course, there's still those who are concerned around a lot of what the media, the internet, there's so much out there on both sides. There's the facts, which are basically that COVID has, killed, millions around the world. And it definitely does impact people of color disproportionately when you compare them to other races. So with that, I'm going to give you some basic facts and then we'll open it up for questions. So here we are. So we were offered the Moderna vaccine at our site. As I mentioned, we're a federally qualified health center in New York. We have several sites, one on the Upper West Side, two in Harlem, one in the Lower East Side. I'm in the Hell's Kitchen site. It's called the Chelsea Clinton site. And then we opened up a new clinic up in Washington Heights. And so the CDC is basically responsible for the shipments of the vaccine to the various sites. And we were, lucky to be one of these sites who been able to offer the vaccine over the past, I want to say at least the last 3 weeks. And we were offered the Moderna vaccine. We know there are various vaccines that are have passed phase 3, which basically means they've been able to show efficacy and safety. The Moderna vaccine is the one that I myself received, as well as those patients who come to obtain the vaccine at the Chelsea site. We know that the clinical trials are those things that allow us to look at how, various demographics, right? As I have a background as a clinical scientist for a pharmaceutical company over a decade ago. And the things that it taught me were looking at not only when a drug is approved that the FDA says it's okay and it passed the regulatory standards, but what about the people who participated in the trials? How many people were there? But more importantly, how many people of color who look like my patients? I have about 400 patients and at least, 75% of them are patients of color. And so I want to make sure that if I am going to recommend something to my patient, not only the vaccine, but other drugs quickly after they're approved, how many people were in the clinical trials. So for the Moderna trial, there were 39,000 subjects that were enrolled. They used 89 clinical sites around the world, and 32 of those were in the US. The racial and ethnic distribution was that of 63% white, 20% Hispanic, 10% African American, 4% Asian, and 3% other. So we know historically that clinical trials and studies is something that African Americans have shied away from. And that is a fact because of the historic issues in terms of clinical trials in this country. Hopefully I don't have to tell too many people who are listening about Tuskegee and the fact that that happened in the 1950s when we did have a treatment for syphilis, and these men in the Army were allowed to go on and develop complications just to see what would happen. And that was wrong. And the US did not apologize for that formally until the 1970s. But with that type of history, among others, that is why we usually don't see a significant amount of African Americans participating in trials. The average is about 6%. So to have 10% participate in the Moderna vaccine was pretty remarkable. And I felt like it was impressive because we do comprise 13% of the US population. So for 10% to be participants in this trial, I was impressed with that. The age range, 64% were over 45, 39% were between 45 and 64, and 25% were 65 and older. I love this pie diagram because it gives us a nice distribution of the racial and ethnicity distribution in the country. So we see Hispanic, we see white, and as I mentioned, the 10% Black, you can see there. Again, this demographics of Moderna in phase 3, which is the last phase of clinical trials, was well represented when you look at people of color.
Wow.
So who took the who is the vaccine going to be for, right? And who did they use in the trials to see how we're going to use it? How is it going to be rolled out? We had over 6,000 Hispanic participants, 3,000 African-American participants, 53% were male. We see that, 14,000 were female. So in a lot of trials, there are usually more males than females. To know that 22% were healthcare workers, to know that the over 65 age group, there were 25% of them. And we did include retail, restaurant, and hospitality workers as well. In addition to an important cohort of patients, which were educators and students. So how does the vaccine work, right? So, there's a lot out there around, it changes your DNA, it goes into your cells. I've heard so many stories and seen so many, messages that I get in my Facebook inbox or Instagram, or just people sending me messages through text that talk about the negative effects, quote unquote, of the vaccine. So these are the basic facts around the molecular biology of the Moderna vaccine. It's a messenger RNA vaccine, right? So when we talk about the cell, I'm just going to go here. When we look at a cell, the inside of the cell, which is the nucleus, we remember that from high school, the nucleus is where the genetic material is. And that's where the DNA is, right? However, the messenger RNA works on the outside, not inside of the nucleus. It's a genetic material which kind of teaches the cell to make material, and then it's destroyed and disintegrates. So once our cells make this spike protein, the spike protein is what's found outside of the COVID virus. Once our cells make a spike protein and display it on the surface, an immune response is triggered, and antibodies, which are normally that material that helps you fight against infection. So this response is triggered and it makes these antibodies from the spike protein, which is on the outside of the cell, not the inside. Those antibodies will protect us against COVID-19. So we'll go over that again. Genetic material that teaches our cells how to make a piece of spike protein. The spike protein is outside of the COVID-19 virus. So see these areas here, the spike protein, that's them on the outside. So 2 apparently successful coronavirus vaccines use the bubbles or the lipid proteins outside to deliver these messenger RNA to the cells. Once they're there, the RNA directs the cells to produce these spike proteins, provoking an immune response to that foreign protein. So with these like fat particles, like connect with the messenger RNA, and they do that job of making these spike protein antibodies. The vaccine will not affect our DNA. Messenger RNA from the vaccine does not enter the cell nucleus. It is impossible for a messenger RNA vaccine to give someone COVID-19. Messenger RNA technology is not new. It's been used for over a decade and been studied in various vaccine trials like the Zika and rabies, etc. And I'll leave in the chat box this link to a YouTube video that goes into more about the messenger RNA vaccines.
Wow.
So how was it developed so quickly? Manufacturing started, early on with the clinical trials, and they're still underway because we know historically we like to be able to prove how patients do, not only after 6 months or even a year. We want to know what the side effects and what the complications and adverse events are out to like usually 144 weeks, out to 2-3 years. Having that kind of data is valuable because you want to be able to tell patients. However, because of the devastating impact this virus has had on the world, they started manufacturing this quickly. And as I mentioned, the clinical trials are still underway. The messenger RNA vaccines are faster to produce than the traditional vaccines that require cultures. So the FDA and the CDC accelerated the process by prioritizing review. Usually you have to wait over time, and they say, wait 6 months, but they were able to really push things through because, again, of the impact that it's had on the world. So what are the side effects? Like Pfizer, Moderna vaccine is reactogenic, which is a good thing. It means that your immune system is working. So when people do feel the side effects I'm going to talk about, that means that they have a good immune system and they're reacting to these antibodies. There have been no reported serious adverse events. They've been mild to moderate, like, some low-grade fever, some fatigue, some pain at the site of the injection. 80 to 100% of recipients complain of mild to moderate injection site pain, which I did have both times. 25 to 40% report fatigue after dose 1 and a little more after dose. Oops, are you guys there?
Mhm,
No. Okay. Oh, my phone, just for a second. After dose 2. 4 to 10% report severe fatigue to miss a day of work. So one of my coworkers, she called in one day and then she was back at work the next day.
mhm.
So what are, again, when we're talking about the side effects. So if people are educated about what that means when they do experience a side effect, that's important to know. Not that it's doing something to them, but it's actually their body's response to having that lipid nanoparticle in them and developing these antibodies. So this just goes into detail about some of the amino acids, acetic acid, sucrose, and the lipids, as we mentioned, that are the ingredients of the Moderna vaccine. Again, I'm speaking mostly about Moderna because that's what we have and that's what we've studied. There's the main difference between, I'll just say up front, between Moderna and Pfizer is the storage and is the number of days between the two doses. Pfizer has 21 days in between the doses, and Moderna has the 28 days between the two doses. Moderna has to remain stable and frozen up to 6 months. It has to be in the refrigerator. The vials, once you open them, they have to be used within 12 hours from the time of puncture. You must use it within 6 hours, but you don't want to leave it open after 12 hours. They cannot be frozen again. And once it's out of the refrigerator, you want to use it. So again, I'll leave these links in the chat box. And this is more about where what we're doing at Ryan. We actually went to some of the local housing facilities where there's residential housing for patients, usually, 65 and older. And we started vaccinating them. The Ryan Chelsea Clinton is in the Hell's Kitchen part of Manhattan. So not only are there people of color, but just in general, low socioeconomic patients who are, poor patients across the spectrum of ethnicities. So I can see in one day, for example, today I had a woman from Saudi Arabia, I had an African patient from Mali, and I had like two African-American patients, and I had two Latina patients, one from Ecuador, one from Colombia. And so I see patients from, various ethnicities. The commonality is usually their socioeconomic status.
Wow.
So we're trying to address that as well. So these are just the guidelines for how we're rolling out, how the CDC has rolled out the virus and who gets it first. And the phase 1 included, of course, the frontline workers, those who work in the emergency rooms and, EMS workers, et cetera, home care workers, the residents of, nursing homes, medical examiner's office, phase 1B, transit workers, teachers and educators. So we're into the first phase of 1B and 1C, which also includes people 65 to 74. I say 65 and older because I have a 80-year-old who received their vaccine today. And then phase 2, which we're starting to enter as of, so we just got an email at 1:15 that said that on the 15th, which is next Monday, that we will be able to vaccinate those with comorbid conditions. So my patients with heart disease and HIV and COPD will be able to benefit from the vaccine. So this was just a panel discussion that we had at Ryan with my medical director and the associate director and myself on the panel.
First, we need to applaud that.
Yes.
I have to say that what you gave to us, people pay thousands and thousands of dollars. I really feel like crying because I'm like, wow, you blessed us with that information. And boy, without knowledge, the people perish. That's what the Bible says. And so thank you so much.
Absolutely. I am so thankful because, there are certain things that I didn't even know that I was like, oh, wow. And just even the use of that diagram.
Yes.
Those that are visual learners, then, it just did something, at least for me. And to be transparent, I had hesitations and maybe, for the same reasons that.
Right. And so did, like in the beginning, so did I, until I saw how many people were in the study who look like my patients and look like me. And, can I say with certainty to be able to recommend to my patients getting the vaccine? Like I wouldn't have been able to recommend it to those who ask me every day if I didn't do the research and we didn't have the information that we do have. And again, the most important thing is the trials are still going on. So we know what we know at this point. However, the next vaccine, like the Johnson and Johnson, which I'm told is beneficial for the various variants, which we're seeing around the world. And now, unfortunately in the United States more, that the benefits of that is that it's one vaccine compared to the two that you get with the Pfizer and Moderna, but also that it is beneficial for those variants. And what does that mean for us who've already received the Moderna? Do we have to get a third booster? So we're learning as we go along, and we're hopeful that the big picture is that it will decrease the prevalence of the virus in not only New York, but in the country, so that we can go back to some form of normalcy gradually, but without being able to address the level of infectivity. And, we talk about these percentages of the infection rate in New York versus even New Jersey. I was talking to my sister who lives in New Jersey, and she was like, oh no, we're good, our restaurants are open. So I'm like, what's the infection rate there? I thought it was like 10%. Ideally last summer we were down to 3. We're like 4 point, I mean, every day it changes a little bit, but the fact that we've come down nicely from like a 10, 11, 12, and we're now in the 4 range is why the 25% opening of restaurants, and we can do that now. So the big picture is the overall prevalence, like decreasing that. My husband's in the background, and I totally told him that I would be on a call. But he is.
It's okay. This is fine.
we all
Sorry.
every day.
He's like, so,
He means that we are humans, and that doctor, you are human, and you have a life.
That's right.
It's okay. So that's, the big picture, and the importance of educating one by one. I mean, I don't think there should be a, patient to feel like there's someone who says, okay, everyone get the vaccine and this is why. It should be, you're in a room, you're able to ask anything and everything that you have concerns around. There's so many questions. I have a patient with MS, and she's like, isn't there one specifically for MS? So, to my knowledge, no, but we do know it's an underlying immune system, problem where you do have to be concerned. However, it would be beneficial for her to get it. So there's so many questions um, along the spectrum of the concern, and understandably, as I mentioned, with the history of clinical trials in this country and how things rolled out so quickly. And it's like, wait, why are we targeting communities of color? But we know that they're disproportionately impacted. And we know people who every single day, when I go to my Facebook page, there's someone passed away from this. And it reminds me so much being in the HIV specialty for over, 20, 25 years, the way that we felt then. And there was so much hesitancy around people of color for even getting tested. I remember that time, but our numbers were continuing to go up, and they still are to this day. Unfortunately, the Caucasian race, right? So there were the numbers when we looked at the risk groups, intravenous drug users, they were gay men, they were heterosexual transmission, and vertical transmission, which means from the mother to the child. The numbers for all of the risk groups have gone down except for African American gay men. Their numbers continue to go up, and I see new patients almost every month, at least two newly infected. And this epidemic has been around for 20, 25, 27 years, and we have treatment that's now tolerable and has less side effects. But the things that have lagged are the education around, HIV. So we to see that now and to remember some of the same stories and some of the same conversations around it's a conspiracy. Whenever I would do a presentation, there was always someone in the audience who asked, well, there's probably a cure and we're not getting it, or they're just targeting us, while our numbers continue to go up. And it's the same thing with this. I just feel that as we continue to die disproportionately when you compare it to other races. So I want to leave it open now for questions or discussion.
Wow.
Right?
I just saw before, I know we do have questions, but I mean, you just, you try to take, I mean, I hope when people watch Soul and Salsa that, they leave our program with one takeaway. I've had many takeaways, but I think you comparing it to HIV is really interesting because also HIV was not, it's not, it's not racist where it's being you're targeting one group. I mean, this was, worldwide. And the fact that without education, I mean, if we don't educate ourselves, then we will never know. So to get the information that you gave, I am visualizing that cell. And when you said that the vaccine, that the medication is outside of the cell, so it's not inside, so where it is going in to destroy you. I mean, but when you get that kind of education, that's why education means everything, whether you get it in the school or whether you get it on Soul and Salsa. It is. Yes, I mean, you really. I too was like Reverend Nilsa. I was very skeptical, even though my husband, took it. And it's funny when he said that he was kind of weak. At first I was like, oh boy, he's kind of weak. That's
Here we go.
They're gonna get the peoples, and oh Lord, but when you said that means you have a strong immune system, that right there, Doc, that was it for me. Go ahead, Rev.
What? I was just gonna say that. That was what I was gonna say when you were talking about, because here's the cell, right? I'm a visual learner, so when I saw that, it kind of like, okay, I got it, because sometimes the terminology, especially I'm like, okay, you lost me. But when I saw the picture, okay, I got this. This is the transition, what have you. But when you talked about the side effect, that sometimes, people like, oh, this gave me this, now this is hurting, you see. But when you were talking about that it doesn't enter the cell, then it cannot destroy you, because it's not really, you're not infecting us with, and maybe infecting is not the right word, but we're not getting that virus.
Introducing it into, right.
into the body, that it is the immune system actually responding to the messenger, right? To the message of,
Right.
hey, this is
Right.
something that you need to fight, right?
Right.
I
There we
was
go.
like,
I love it. This see that really
Yeah.
breaks it down.
and I'm not an expert medical, but I
No,
understood it
but
that
seeing that and
way.
being able to break it
It make a
down
difference.
even more so in a
Yes.
clearer, concise way, because sometimes I'll use the medical terminology, but see intelligence with that you have with taking that and spelling it out even further so that it makes it you can visualize that as you mentioned, being a visual learner. It's like you heard what you heard, you saw what you saw, and you made it, and that's just so important and so key.
Mm.
I was going to show, I actually have this other little video clip. Again, I'll put it in the chat box, but it shows the whole messenger in such a nice way. It's just the coolest little video, and it's on YouTube, and it shows the messenger RNA just doing its job in a way that spells out. See, every time I try to put this in, it
So,
doesn't.
Doctor, while you doing that, let me ask you, because some of the questions that we got or the
Okay.
people posted or text us was that, and I didn't know, because you got all this vaccine,
Mhm.
Pfizer, and then now the Moderna, whatever. And they were saying that the hesitation was that really, and maybe they were referring to Moderna, and I'm not sure, that why they were cautious and they had hesitations is because in for vaccine to be a vaccine, you needed to get the virus, right? Like if you get the cold, the flu is because they infect, they giving
Right.
you introducing the virus, and that's how you're gonna get immune.
Right. But
So that
not
was
all. Yeah. But not,
yeah. So
yeah. So not all vaccines give you the actual virus.
okay,
There's different types of vaccines. So recombinant is like, so hepatitis B, for example, that vaccine that people get one the next month and then 6 months later, that's not the actual hepatitis B vaccine.
Mm.
The annual flu, the seasonal flu vaccine, which is the predominant strain that's been determined to be the flu vaccine for that year. That changes every year, but that's one of the ones that is based on the viral strains that they've noticed around the world. And then by the time it gets to the United States around September, October, that is why that is that specific virus.
Mm.
And then you develop antibodies. That's the seasonal flu. But other viruses, for example, shingles, the Shingrix, that's a virus, but that's not the actual that's not. So there's so many. We don't have a virus. We don't have a vaccine for hepatitis C. We have it for A and B. Um, Herpes or shingles is another virus. So yeah, it varies. There are different types of vaccines that are made. Not all of them are the actual virus.
okay, but that's
So that's why with this, it's
yeah.
not the actual virus.
People may think, oh, for this one they didn't put the virus, or because of that is not actually a vaccine. But it's good to
Right.
know what you just mentioned, that
Right.
other type of vaccine that do not necessarily have to be whatever created. Forgive me if I'm not using the right
Right. No, no, that's no, you're absolutely
with
right.
a virus formula or whatever, right?
Right. Right.
And
Okay.
also, I had did a little live on Facebook while you were sharing, and my inbox is over flooded. So they're like, you should have done it live. I'm like, okay, we'll go on YouTube and look at the full recording. Okay. But one of the questions is, that's why I kept looking down. So excuse me that I
Okay.
was
That's
looking
okay.
down. They said, is there a risk that New York State will run out of the vaccine before I have to get my second dose? Doc, ask the doc.
It shouldn't be so the reason why when patients ask about being on the list, quote unquote, there's not really at Ryan, we just have a soft list, right? So every site has how they are dividing the vaccines up. Each time they use one, they have to have the booster. You can't get one question that had come up before is like, if you got one can you get a different vaccine for the second? No, you have to use the same vaccine. So you can't get Moderna for the first and then Pfizer for the second.
Okay.
There is such careful documentation that's being done around the number of people who come in for the vaccines. So as far as I'm told, and as far as we know, there shouldn't be a problem with getting the second vaccine. It's not like when they allocate the first vaccine, they document that that's 2 vaccines.
Okay.
So they'll have enough for the second. And they are given a card that shows that they received the first one.
Okay.
And there's, more vaccines being shipped every week. It is week by week. And then once it gets there, it's day by day. And then once it's that day, it's literally like hour by hour and then minute by minute. I cannot even tell you. Today we, on our, I'll just show you that
Hi, Freddie.
Freddie, ¿quién está hablando? See, he thinks he can speak Spanish. That's what he said.
We have to show Freddie. He's been talking. We'll be like,
he's Italian and he thinks he's just say hi. Say hi. This is Soul and Salsa.
So the one,
so we should be fine.
Already answered because someone said, "Can I mix and max vaccine?"
No.
That question is answered. The other one is they said, like Reverend Nilsa, I'm moving to Florida. Can I get the second vaccine in another state?
They should really wait because they should really wait. It's not really because it's part of the first vaccine, right? It's thought to be as a booster. We know that the antibody levels decline over time. That's how they determine if you need a second vaccine. And so it's better just for the numbers and just the allocation of the second vaccine for that patient. Oh, hold on one sec. I'm so sorry.
Wow.
So sorry. The on call center.
That's
Sorry.
interesting.
Hello?
And actually, that was a good question because you could think that.
Yes.
Let me go to another state. Hey, I got the first one. Give me the second one. But it might even not even.
Okay, hold on one sec. So
exactly.
So it's the call center. It's the call center. Can I chime back in?
Yep.
Okay, I'll chime back in.
Okay, no problem. No
I'm
problem.
so sorry.
We'll
I'm so
continue
sorry.
talking.
I'm sorry.
That is the job of someone who not only is a boss, but on call for the community and for the people, and then she has to be like on call. So even if that's it, right? We are so blessed. And if you have any more questions when we upload this episode tonight before 10 p.m., hopefully before 9, you will be able to put your questions in the chat. This is serious business.
Yes, if my Latino folks, si otra vez necesitan alguna pregunta contestada de la doctora Marlene, póngalo en español, no se preocupe, esta servidora lo vamos a traducir. Doctor Marlene, para que los que no sepan, habla español. Ella no es latina, ella lo entiende, lo habla, ella puede entender también su pregunta. So, por favor, nuestros latinos, pongan su pregunta, importante.
Did you hear her? Did y'all Spanish? Did y'all hear that Spanish right there? Because she told y'all got to get up on it. So who's your guest? Oh, look.
Yeah, New York City, Brenda, the famous Brenda.
Famous Brenda. Hi, Brenda.
Yeah, Brenda does have some health issues. So, Brenda, how does this help you? Because Brenda is a diabetic, right?
Yeah.
So,
my question to her will be how effective it is, how long it will last in our system, and if later on, we have to go through. No, later on. Or do you, or can you get COVID after you get the vaccine?
Right. And as we talked last week, things are not, if we see any changes, it's going to be so minute. So I want to ask you, because, this whole thing, there's a lot of just total in Florida, Florida's getting a bad rap. Well, because you got certain neighbors there, but Florida is getting a certain rap in terms of the mask and the distancing. Can you speak to that? And how is it compared to New York?
Well, let me tell you something. At least in the area that I live and the people that I have interacted with, I actually was surprised. And Brenda was here today, and
I haven't seen that one person without a mask here.
Wow.
In the restaurants, you barely see maybe one or two, and it is because they going at a distance. We actually have a walk by the lake that we do. I do a prayer walk every day, and people actually, if they passing you by, like for instance, there was this couple that they were running, so they had it off because they're running. She put her her t-shirt in her mouth, when we were passing by.
Wow.
So, I can, of course, not speak for the entire state of Florida, but I could say the people that I have interacted with and here in Miami, that has not been my experience. Now, with that said, yes, I went to Miami Beach, and that was a different story, right? But the same can be said for New York.
Right.
When bars were open and people, and you have people and a couple of drinks and some music, and
yes,
the mask will go off. So I don't think that is just particular of a state, in my opinion. I think that if you put those ingredients everywhere and depending, then you're gonna have same reactions.
Okay.
But at least in my view, for now in this area that I live in Miami, I was actually surprised because again, people were saying, "Oh, Miami, be careful," but I haven't, haven't gotten that experience with the people I have been interacting.
Okay, now for Brenda, the fact that you traveled from New York to Florida, was there any precautions that you had to take or that were mandatory before traveling?
Yeah, you have to have a mask. You have to well, you got to get screened and all that.
Yes.
But your hands sanitized. They tell you do not take your mask off. If you take your mask off, we will escort you out the plane.
Oh, really?
Everybody had their mask.
Okay, I'm back. Great.
Wow. Wow. Dr. Taylor, we were just conversing and really just applauding you once again and thanking you so much for the information. And Brenda has two questions for you if you don't mind answering.
Okay, no problem.
I want to know if you
Brenda.
Hi, how you doing?
Good.
I would like to know if once you get the vaccine, is it possible for you to get COVID once you get the vaccine? And how long does it last?
Right. Okay, so that's a great question. So we know that the vaccines that are offered and are approved for use, there's over 90% efficacy against COVID-19. However, as I mentioned earlier, there are these variants, which are different strains of COVID-19, so which are more fatal and just have different side effects and complications that have been shown to be more severe. So if someone is exposed to one of those variants after they have the initial vaccine, it's possible, but it's unlikely because of the coverage that they do have. So you almost want to have something as opposed to nothing, because at least with the 90% efficacy against COVID-19, the one that's more prevalent, you have that coverage. The variants are they're not that common, at least not yet. So if you have coverage for the predominant strain, then it's better to have that than to think that maybe I'm going to get it anyway. That's not the way to think. You have to think of the fact that the vast majority of patients who have COVID-19 is that predominant strain that we see in the US. And are there these new variants that people can be exposed to and get? Yes. But it's unlikely when you have that vaccine already on board. That's pretty much covering you with 90%.
Wow.
And
Wow.
with the
You
second,
shouldn't get, and so how long does it last? So that's one of the things that we are getting information about, and why we're saying now that it's definitely out to a year, in terms of the way that how long it should last. Some vaccines, as I always use hepatitis B because that's a virus, and we know that the initial dosage, it declines after a month. So you get another vaccine the second month, and that lasts out to 6 months. And then at the 6 month mark, they get a third vaccine, which will last for the next until the next. Actually, that should cover for like indefinitely. So when you look at viruses, you want to see what their antibody response is, how long it takes to decline the antibodies, and what they've seen with COVID-19. And that's how they came up with the booster, because they know that after a month, the rate of the antibodies present starts to decline. So then you give another one. That's for the Pfizer and Moderna. For the Johnson and Johnson, it's different. That one should cover for a year. But again, that's the data as it's come out. Like, we're doing this in real time. Most viruses, you have data to say, in 3 years, we've seen this. In 5 years, we've seen this. We're just at the 1 year mark with COVID-19, period. So to have the data we have is really reassuring, but it's also, we can't say with 100% certainty. But when you look at how many people are dying and how sick people get, you want to try to get something out there that's going to address just making a difference for the overall population.
Okay.
and that makes sense, at least for people like us that are not experts, because again, if it's only been a year, you can't have this miracle vaccine
Right, to
and take
say,
it all away when it
right,
keeps changing and changing.
right.
It is a process. So I applaud you, and I applaud the medical field and those people that are trying to do something versus not doing anything, right?
Right.
So at least we know that it's still a process. We're still learning in the
Mm-hmm.
process, and
Right,
with every learning process, right, that there's going
right.
to be things that would work,
Going
and
to
then
be changes, right. I mean, not to again use the HIV epidemic, but the one drug we had early on, AZT, it was all we had. And for some people, it kept them alive until other drugs came around that were FDA approved, that were with less side effects, less toxicity, better tolerated, and better, I mean, overall efficacy. So we had something to tide people over, and so many people, I remember, were like, I'm not taking anything, we're not guinea pigs, it's making your bone marrow. The only dose we knew was that toxic dose. We look back and we say, how do we give 500 milligrams 5 times a day? Now it's not even, it's no longer used. However, it's all we had to tie over until we got better drugs with less toxicity. So it's not to think it's the same exact thing, but it is something compared to, I think of, a dear friend of mine who was one of my college roommates, and she was taking care of her mom and dad. The mom had COVID. She was going over every day. The dad, I believe, was in a nursing home. The mom passed away. She went home a few weeks into taking care of her mom and started coughing, and one night said she felt better, but she passed away. I mean, and then the dad died a few weeks later. So when you think of whole families wiped out, not in the inner city, like upstate New York, where this is unheard of, like, what does that? This virus is tricky, it's smart, and it does what it does. It doesn't, it likes to see, COPD, low immune systems, uncontrolled diseases. My patients, the 2 patients out of my 400 who have passed away from COVID, one stopped taking his HIV meds then January of 2020, and he passed away in April. And he was my patient at least, 15 years. And he just decided in January he wanted to take a holiday. And that was, just sad. And the other patient just recently had severe COPD and was a smoker. So really bad lung disease, but someone I saw every month, and he even called me when he was in the hospital. He didn't think he needed, that they were going to put him on a ventilator. And then I found out a week later that he passed away. It's really, about us using what we have to help to address the overwhelming number of deaths in the world.
Just we send our condolences with your, patients who have passed away. And we're talking all about adults. And so someone had a question, but I feel like I have that same question with a son who is 15 years old. And it says, since there isn't the vaccine for children yet, where is this vaccine for children? And how is it going to affect our children if two parents or one parent gets the vaccine and your child doesn't?
Mm-hmm. So the data around children and the vaccine, it's not quite, I'm hearing in the next week that we should have some solid data around children and both of these vaccines. I think that, the best approach to everything is doing what has kept New York, even before the vaccine, what allowed us to have numbers and the infection rate below 4%, 3%, which is the hand washing and use social distancing and the mask. If you do that at home, so if both parents have the vaccine, then is the child at risk if he goes out every day? But if he protects him or herself, by doing those things, he should be fine. So it doesn't really impact directly if the child is not using a mask and they're putting themselves at risk. But as long as he does that, until data show that it is safe and efficacious and effective in children, I would just continue to have him do that.
Okay.
To wear a mask, even some people say even at home, depending on who he's around. Everything is about the pod, right? The group that we're around. So, it's Jason, Freddie, and I go to work. And when I come in, I take stuff off, go right to the bathroom, because I'm around a number of people every day, potentially exposed to something on the way going and coming from work. So they're here. So if you're around large groups that you don't know for prolonged periods of time, I've heard stories of so a friend of mine whose wife is a teacher, he told me that she tested positive. So she's going into the school every day. They have 3 children. And so he called and said, what should we do? And I'm like, go get tested right away. And they all were negative. So the wife isolated for, now it's 10 days. And, now they all remain clinically fine, as well as the wife. So it's getting the information about everyone and then doing what we know we can do and what's been shown to work for prevention of developing COVID.
Wow. I have one more. Now I feel like this is a myth, but people are like, so we got a call. Someone wanted to come over and visit, and I just looked at my husband with a side eye. I was like for what? I mean, and the thing is that they didn't get tested. They didn't do anything. And they're like, oh, but I'm good because
how do they know?
We can, and we just had to say, no. So a friend wrote on Facebook that he had a friend come over. The friend, they were 6 feet distance. They washed his hands. He did everything, and they had conversation. They had a great time. And 3 days later, the guy called him and said, I have COVID. And then he got tested. His test was negative. but what he was saying was, I did everything right. And so that's
But
why,
how does he know? How does he? So the
right?
person who tested positive, I mean, the person who tested positive, had he been tested before he went over to the friend's house?
No,
See, that's it. He
right.
could do all that, but when in terms of entering someone's, I'm going to call it pod,
Mm,
just like in the clinic, a pod is the cubicles we have for patients to come and sit and wait in the waiting room. Now, we try to get them in and out as quickly as possible. So there are 4 seats in that pod, and there's a partition between each pod. We try to get people in and out of that. Even though they're 6 feet apart, studies show that it's prolonged exposure. So if that person had COVID, I mean, unless you, so 2 things. One is when you choose to allow someone in your space, your home, your clinic, things have to be done. I mean, the thermometer, so one thing we did at my church when my best friend's brother's funeral. So of course she's coming from another state. She came from North Carolina. They were, so I had the thermometer. So that was like people coming from all over. We're in a large space. What we knew to do is to try to socially distance as much as possible, but also taking temperatures.
mhm.
Ideally, we would want to say everyone should have a test within 3 days. She couldn't come to New York without that test from North Carolina. So when you go into a closed space like your home, that people definitely should have a test. Even the social gatherings around the holidays, I know of so many friends who said they insisted on having their friends have a test and show it to them that they had the test within 3 days. Even if you try to do everything, the infectivity, if
Mm.
that person is highly infectious, because there are different degrees of infectiousness, right? So someone could have just been exposed and have a high viral load. Whereas if tears come out, they're crying about something and they just rub their eyes and they touch a surface, someone can touch that surface, even if they wash their hands and it could be absorbed and the other person touches, that's it. Whereas someone else who might be at the tail end of the viral load going down, they're at the end of their 10 days or 14 days, and they can do the same thing. But it's like we're looking at a snapshot of each person every single day. So you don't know if that's like when someone tests positive, we don't know when they were first infected. We're
Mm.
just saying they're infected that day, and we're saying that they have to be in isolation for 2 weeks, well, 10 days now. But we don't know if that might have been the 7th day of them being infected. So we have to always remember that we're doing snapshots of the data. That's why the perfect thing, which is totally impossible, would be people getting tested every day. You have the data, their 14 days. For some people, their tests stay positive even after 2 weeks. We have someone who I know who worked in a clinic. Her husband was positive. She tested, she was positive. She needed, her employer was like, when are you coming back to work? She was totally asymptomatic, but she stayed home for 10 days. Her test was still positive, but she was allowed to come back because she quarantined for 10 days. Now, does that positive test mean she's infectious? She's less likely to be as infectious as she was at the beginning of the 10 days, day number 1, because we know at the end of the 10 days, the viral particles are not, they're dying off.
Mm.
So even if the test is positive. So imagine if she never got tested and someone sees that positive test, right? If you know the history, then that helps with the big picture, because you can't come to a conclusion about what's going on with the patient until you know their story and how many tests they had before, when that was, who they were around. You have to put the pieces of the story together to say, to make a conscious decision about what that patient should do. So that person, I don't know, had they gotten a test 3 days before, it probably would have been positive. right? Maybe even if it wasn't, who knows if it would have shown up the second day. And then the third day he went in to visit the friend.
Mm.
So you can do all that. But it's about knowing that person's story. But so I recommend before anyone lets someone into their pod, they should get tested
You
within
know,
3 days.
it is good. I think it's about, in my opinion, personal responsibility too. I know
There
when
we go.
we were
That's a great,
we went and got tested. Then we had a little scare, actually, someone that came to do some work in the house. And although, again, we were wearing masks and we were social, we were not even in the room when they were doing the work. But immediately, my and my husband went and got tested. I told everybody that we were close to, they went and got tested. We were negative. Um,
okay.
Everybody that we were in, we made sure that, okay, you know what, get tested. Oh, they, you have to know.
Right.
I mean, it might
You
not
have
be
to know. Right.
sure because, if you have to get out, we have to work, we have to do,
Right.
and, the trusting issues. But
Right.
please, I believe that if, as a person, if I'm responsible and I'm going to go visit Michelle and I'm coming from over here, then
Hmm.
you know what, let me get tested. And then not only I say I get tested, I could say I get tested and I didn't get tested. I actually
Show
send my negative
results.
result
Yes. Yes.
Yeah.
to
Yes.
the person that I work with, and I'm like, here's the result. So
Right.
so you
That's the responsibility. It's a great way of
know
framing it. It's right. It's
Okay,
so
so
important.
but what if you, so is it safe to say that if you get the vaccine, because a lot of people feel like, well, now I got the vaccine, I can hug you and
Mhm.
you can't get it. I mean, people are
Mhm.
walking around like I
Yeah.
got the vaccine, so basically everything is okay.
Mhm. Not until.
So the question is, if you get, when you get the vaccine, does that mean that you are immune to getting the COVID, and are those who come toward you, are they protected because you got the vaccine?
No, for they protected from you. So the the general answer is, are you safe from getting the exposed to COVID? Are you safe from getting COVID? Obviously that's why you get the vaccine. However, until the overall rate, I keep saying this because it's about, in public health, we talk about populations and the overall rates in different groups and different, I don't mean socioeconomic, I mean like where you live, and the Bronx versus Brooklyn versus Manhattan. So that's what we are addressing. So until those rates go down, um, then people should still behave and do social distancing and wear their masks and hand washing, because how do we know if they could be exposed to someone with a variant strain? On the train, you could touch the pole and someone could be coming in from Port Authority and they could have, touched the pole. So for them to think that they're totally safe is irresponsible. Are they, for the most part, in a better place than had they not gotten the vaccine? Of course. But until we get the data to say, okay, the last 3 months, we've seen the infectivity rate in Manhattan go from, 10 to 2%. And people can, I don't think it'll be that people don't have to wear masks, but at least things will start gradually. It has to be done very gradually because there's so many, we're such a closely, densely populated. I'm thinking of Manhattan and the Bronx. Of in New York, closely, the density is compared to other parts of the country and other parts of upstate New York and, even parts of Long Island. So we have to be very diligent with, there's the big picture of what it looks like in New York and in the country. And then there's our own, as Nilsa puts it, like responsibility. And so just the CDC website, I cannot say enough about how things change day by day based on the data. But I think not wearing a mask is not something we'll see in the foreseeable future. in the next few months. I don't see that. Do I see things gradually opening up? Yes. Do I see the numbers improving? Yes. But these variants, we have to see where that goes, because that's going to be based on how many people get vaccinated and how many people continue to be responsible with social distancing, et cetera. So if those variants don't grow and overtake the what we call in HIV the wild type virus, which is the main virus, if the main virus dies out, which is what we hope, and the variants don't get a chance to populate, then we're good, by the fall, I see.
Oh,
But if we don't do that, then things are going to be going up and down, and it's just, continues to be a challenge.
But we don't want the variants to populate. That's
Mhm.
that's my takeaway. Very, very, very clear. The time is well spent. I mean, we could be here all
I
we want to say, thank you. And there's really no other way. Like what you gave to us, bar none. Yeah, because you're right in the heart of the city. And so you are dealing with people who look like us, like Nilsa. Nilsa, can you, when I had asked you, like, what did you,
Thank you.
how did you feel? And you talked about the three things. Can you say it again? Because she didn't hear it. About the trust, and then.
So I was just saying that there were three things. These are the three things that made me, say, okay, let me hear about it, right? One, especially in our culture, is trust, right?
Mhm.
But the fact that you were Michelle's mother's doctor and a family doctor, that alone carried a weight, right? The second, it was the fact that you look like us, right? That carried the way. And then three, that you are the expert, and that what gain do you have in saying something else that is not perhaps true in your field, because
Mhm.
at the end of the day, when you look in the mirror, you are an Afro-American woman.
Right.
If
There
you
we
try
go.
to do this, then you will be part of it too. So
Right. Listen,
welcome.
y'all, you don't want to miss the next installment of our next episode is when Nurse Drew from Arizona is going to be giving her take on the vaccine. And again, what we say is take the information and make your own decision. But at the end of the day, it's still going to be
Sol and Salsa.
Salsa y Sol. So we thank you for being with us, and we will see you next time.
Yes.
Thank you.
Gracias.
Thank you.
Adios. Adios.